How you doing? I'm Mike Lorena. I'll be your nurse anesthetist for today. Can you start off by stating your name and date of birth?
Amanda McGreetus, December 8th, 1993.
Okay. Do you have any allergies to any medication?
Penicillin.
Penicillin?
Mm-hmm.
Okay. Any medical history?
No.
No? Okay. Surgical history?
No.
No alcohol or drug abuse? No. Okay. Do you know why you're here today?
For physical.
Physical? Yes, that's correct. What we're going to do is a three-part physical. I'm going to assess your neurological, cardiovascular, and pulmonary assessment. Okay. Do you know the date of birth? Or not the date of birth? I'm sorry. Do you know today's date is?
July 19th, 2017.
There you go. Do you know where we are exactly?
We're at the hospital.
We're at the hospital. Beautiful. All right. The patient is alert-oriented to time, place, person, and situation. I'm going to move on to the cranial nerves. It's a series of tests. Might be a little awkward, but it has all of its purposes. Okay. Okay. The first test that I'm going to do is cranial nerves 3, 4, and 6. It's ocular motor, abducine, and trochlear. Okay. The first thing I'm going to have you do is look right at my nose.
Mm-hmm.
Okay. I'm going to shine a light in your eyes. Beautiful. Okay. Patient's pupils are round, equal, and reactive and accommodating for light. Next thing I'm going to do, I'm going to have you keep your head real still.
Mm-hmm.
And follow my finger with your eyes. Okay. Beautiful. Okay. We're going to move on. We're going to move on to cranial nerve number 5, which is trigeminal. Trigeminal. I'm going to have you just clench your jaw. Okay. Loosen your jaw up a little bit and move it side to side. Beautiful. Okay. We're going to move on to now cranial nerve number 7, which is facial. I'm going to pop out your cheeks. Smile. Close your eyes real tight. Open them real wide. Beautiful. Alrighty. There's another part to that test. I've got a soft object and a sharp object.
Mm-hmm.
Okay. So this is soft and that's sharp.
Okay.
So I'm going to have you close your eyes. Soft or sharp?
Soft.
Soft or sharp?
Sharp.
Soft or sharp?
Soft.
Soft or sharp?
Sharp.
Soft or sharp?
Sharp.
Soft or sharp?
Sharp. Soft. Sorry.
There you go. Soft or sharp?
Sharp.
Soft or sharp?
Soft.
There. I think I just poked real hard. So, alright. That concludes cranial nerve number 7, which is facial. We're going to move on to cranial nerve 8, which is vestibular condylar, which is what I'm going to do. I'm going to have you close your eyes, not right now, but can you hear that?
Yes.
Okay. I'm going to have you close your eyes, and you're going to tell me which side you hear the actual rub in my fingers.
Okay. Mm-hmm.
So close your eyes real tight.
Left. Left. Right. Right.
Beautiful. Alrighty, we're going to move on to cranial nerve 9 and 10. 9 and 10 are glossal, pharyngeal, and vagus. I'm not going to stimulate a gag reflex. What I'm going to do we're going to just stick out your tongue and say ah. Beautiful. And swallow. Beautiful. Okay. That's all. What we're going to do now is vagus or cranial nerve 11, which is accessory. I'm going to have you shrug your shoulders. There you go. Shrug against my hands. Sorry. There you go. I'm going to have you turn your head. There you go. Turn against my hand. There you go. Turn against my hand. Awesome. We're going to move on to cranial nerve number 12. Cranial nerve number 12 is hypoglossal, and it's I'm going to have you stick out your tongue and move it side to side. No. There you go. All right. That concludes the cranial nerves. What we're going to do now is position sensory. So what I'm going to do, I'm going to take your hand. All right. And open your eyes. If I go like that, it's up. That's down.
Okay.
Okay, so close your eyes one time.
Down. Up. Down.
Beautiful. Okay, next one.
Down. Up. Up.
There you go. I'm going to move on to your toes. Close your eyes.
Up. Down. 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 Up.
Let's restart that. No, you're fine. You're fine.
Down. Down. Up.
There you go. It was mine. All right, we're gonna move on.
Down. Down. Up.
There you go. Okay. We're gonna do the same stuff or same thing that we did for the facial nerve. Okay, so it's soft and sharp. Okay. I'm gonna do it on your arms and your legs.
Okay.
So remember, this is soft and that's sharp. Okay.
Sharp. Sharp. Soft. Sharp. Soft. Sharp. Sharp. Soft. Soft. Sharp. Sharp. Soft.
There you go. That concludes the neurological portion of the assessment. We're going to move on to the cardiovascular part in a few minutes. Again, I'm just going to start by asking, do you have any medical history, cardiac-wise, hypertension, any heart attacks, surgeries in the past, that broken heart? Any problem with swelling in your legs, lesions? You're not diabetic as well?
No.
No smoking?
No smoking.
Okay. What I'm going to do first for this cardiac assessment, I'm going to test your peripheral vascular system. I'm going to start with your carotid artery. I'm going to listen to if there's any breweries in your carotid artery. I'm going to place my belt on the stethoscope. No brews are heard. I'm going to palpate one at a time. +2. +2. Skin is warm, dry, and pink. Skin turgor is elastic and brisk. Cat refill is less than 2. There is no signs of clubbing or deoxygenation within the tissues. I'm going to check your radial pulse. +2. Your brachial. +2. Left side radial pulse. +2. Radial pulse on left side. It's +2 as well. I'm gonna skip your femoral pulses. I'm gonna move on to, but if you were to check, it would be right here in the inner gut line. I'm gonna move on to the popliteal pulse. That's +2 as well. To the left side, +2. Dorsal pedis, +2. Dorsal pedis. Post-tibular pulse +2 as well, and the right side is +2 as well. There's no swelling or edema within the legs. Are you having any pain in your legs?
No.
Nope. I'm going to check for DVTs with the home sound and we'll bend, and I'm going to push back on your leg. Any pain when I do that? Beautiful. Push with my hand. Any pain when I do that? Okay. If there was a positive pain when I did that, I might put her back into a Trendelenburg leg raise, which is pretty much I lay her back, lift up her leg, I place a tourniquet around the leg, let the blood pool in her leg, and release the tourniquet, sit her up, and if the blood should return back to the heart, if it doesn't and pools in her legs and in the vascular system, there's a problem with her valves within her legs. and I could order a ultrasound for further diagnostic. I'm going to move on now to listen to our heart sounds, okay? I'm going to first listen to her aortic valve, which is the right sternal border, second intercostal space. Her pulmonic valve, which is left sternal border, second intercostal space. Tricuspid, which is, I'm just going to move there, sorry about that, which is the fourth intercostal space, left sternal border. And then I'm going to listen to the mitral valve, which is mid-clavicular line on the left side, fifth intercostal space. I'm going to have her hold her breath while not yet, I'm going to have her hold her breath while I check the apical pulse, or listen to the apical pulse for a minute. Go ahead and hold your breath. Go ahead, pulse is 75. If I had a hard time hearing her heart, I can lay her on her side. Usually it's on the left side to push the apex closer to the heart, to the base, or to the actual rib cage. S and S2 is sounds are best heard at the base of the heart. Those are your aortic and pulmonary valves. S1 best heard with the diaphragm, and both with diaphragm of the stethoscope is heard at the apex of the heart. S1 closing of your the mitral and tricuspid valves. Okay. There is if you were to listen for extra heart sounds, you take your bell of your stethoscope and you can listen for extra heart sounds. Extra heart sounds mean that there is murmurs. There's two types of murmurs, or two types that cause murmurs. It's stenosis, which is the narrowing and opening problem of the valve, and regurgitation. Regurgitation is a closure problem. They're graded on a 1 to 6 scale. Common pathology is found within the left side of the heart. That concludes our assessment of the cardiac section. We're going to move on to the pulmonary. All right, Amanda, what we're going to do is move on to the pulmonary and actually the chest inspection. What I'm doing now is visibly looking at her chest, making sure there's no exertion on respiratory drive. There's no pulsation or heaves. I'm going to actually feel no heaves, no pulsation. The only pulsation that I feel, and it's in 1 centimeter diameter, is the apical pulse. If it was greater, it would mean that there could be hypertrophy in the axial heart. Now I'm going to have her actually move to the side over here, and we're going to do thoracic expansion. Thoracic expansion, I'm just going to wrap my hands around T10, have her breathe in really deep, beautiful, and she expands. Her expansion was greater than 1 centimeter, which is normal. Now I'm going to have tactile feminist. I'm going to have her repeat 99 and move my hands down her actual back. Okay, so whenever you're ready.
99, 99, 99, 99, 99, 99,
Beautiful.
99.
And now I'm going to use my ulnar palm, the ulnar side, to do the same thing, and she's going to repeat 99 again.
99, 99, 99, 99, 99, 99.
Okay. What I'm going to do now, I'm going to listen to her lung signs at the back. Take a nice deep breath in. Listen to the sounds. I'm also going to percuss. I'm going to have you now move over to this side. I'm going to just listen to your lung signs on the front. Just listen to this. Okay. One more. I am actually now going to listen to her back while we are going to do vocal rhythmcy. The first thing that we're going to test is bongophony, which is what I'm going to have her do is say 99, and I'm going to listen to all the lung fields again. You can stay right there. Say 99.
99, 99, 99, 99, 99, 99, 99, 99, 99.
I'm going to test egophony, which is what she's going to do is I'm going to say she's going to say E. I'm going to listen to the same thing as all four or all lung sounds in the back. Go ahead, say E.
E, 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 E.
And then what we're going to do now is a whisper hectoriliquy. I'm going to do this, she's actually going to whisper 1, 2, 3 while I listen to the lung fields in the back as well. And sounds are muffled and indistinct, which is normal, so there's no consolidation within the lung. That concludes our pulmonary stuff. All right, Amanda, now that we got you laying down, and what we're going to do is assess your JVD and your jugular hepatic reflux, okay? The first thing we're going to do is your JVD. I'm going to have you turn your head towards me. We have her at a 30-degree angle. I see her JVD, but it's not engorged. It's at that level right here, which is a good level. What now I'm going to do is the hepatic jugular reflux. I'm going to place my hand and push down on her liver until her JVD engorges, and it's pretty uncomfortable, I'm sorry. And it's engorged right now. Now I'm gonna relax it, and it should go down. Her JVD does go down. If her JVD did not go down and stayed engorged, then it would mean that there could be a right-sided heart failure. That concludes our assessment. Thank you very much, Amanda.